thanks everyone for tuning in on our Monday afternoon Facebook Live. I'm Lynn Hundley, the founder of United Stroke Alliance, and as most of you know, our nonprofit focuses on prevention, awareness, and recovery from stroke, so we're glad to have you here with us. I'm very, very excited about our guest this afternoon. She comes with great reviews and a great bio. The folks at Medtronic, which we've had a relationship with for a long time, that have been very, very helpful in supporting us and helping us educate our population, suggested Lynn as a guest speaker and the topic that we're going to talk about today, which is cryptogenic stroke. So I'm going to let Lynn give a brief introduction of a little bit about her history and such, but today we are hoping to educate stroke survivors and caregivers about cryptogenic stroke, and it's one of those stroke with no known cause. And then one particular device, one particular strategy, if AFib is the reason that you had the cryptogenic stroke. So Lynn, you want to give a little brief introduction and describe what cryptogenic stroke is, and then we're just going to do a little question and answer. And you're looking fine. Your blur is gone.
Oh, awesome. Well, sounds good. Thank you very much, Mary Lee. I appreciate you guys having me to talk to you tonight. I love to educate people about stroke. It's kind of my thing. I have been working in the stroke world since at least about 2000 and I would say two. And helped build stroke centers in my previous job in Louisville, and now work for Norton Healthcare. And I'm actually the director for the stroke program for all of Norton Healthcare in Louisville, Kentucky. We are a 4-hospital system in the city. We have a comprehensive stroke center, 2 primary stroke centers, and an acute stroke-ready stroke center. And then we have our own critical care transport team that moves our patients around as needed. So anything stroke falls into my umbrella of responsibility. I've been speaking for Medtronic for several years on cryptogenic stroke. I started doing that when we started using these devices that you're going to hear about a little bit later to implant to monitor for atrial fibrillation. So I would say at least since 2013 or 14, I've been on the Speakers Bureau for cryptogenic stroke. So in the stroke world, I think for some reason, since we're neuro, we like to make up words for our stuff that sounds different than everybody else's. So in any other disease state, if you have something that we don't know what it is, we call it idiopathic. In stroke, we decided to call it cryptogenic because the cause of your stroke was cryptic. How about that? It means that you had a stroke and we don't know why you had your stroke. One of the things when you come to the hospital with a stroke, our job is to find out, of course, other than taking care of you, obviously, and it takes a village to provide good stroke care, but our job is to find out why you had your stroke, because then we can prescribe you therapies or other things to help prevent you from having another stroke. I'm sure you realize, and I'm sure if you're on here, you're either a caregiver or a stroke survivor, you know that you're at a higher risk to have another stroke once you've had one. That risk goes way up if we don't figure out why you had it. So, and we can't put therapies on board to help you manage all of those risk factors to prevent you from having another one. So some causes of stroke that you probably know about, risk factors, high blood pressure, high cholesterol, those things that clog up our arteries and wear them out. Those are what we call atherosclerotic strokes, or they're caused by the blockages in your arteries. They can happen in a large vessel, like your carotid artery, this big one that feeds up into your brain. Or they can happen in, and we'd call that a large vessel occlusion or a large vessel stroke. They can happen in the smaller arteries in your brain, those blockages, and deep inside your brain, way deep inside there where it feeds the inner structures of your brain. And the smaller vessels that get a lot of pressure damage from high blood pressure, they get a lot of plaque buildup in there, and also things like diabetes and smoking and all those things cause stress and wear on those arteries. And strokes that occur in there we call small vessel strokes. We can also see strokes caused by clotting disorders. And let me back up just a minute when I go there. We're talking today about cryptogenic stroke, and the focus of our talk today is also going to be about the kinds of stroke that are caused by blood clots, okay? So what those are ischemic strokes. You can also have bleeding in your brain or hemorrhagic strokes, and we're really not referring to those today. Hypertension or high blood pressure is the main cause of talk about in the realm of cryptogenic stroke, we're going to stay over on the side for ischemic stroke, or those strokes caused by blood clots. So the blood clots that cause those strokes can happen in the vessel, like those tiny vessels that I talked about, small vessel. The plaques in there rupture and you have a blood clot, and that causes a stroke in that area of the brain. You could have clogs in your large vessel, your carotid artery, and you can start to get clots there from the decreased flow. So the flow slows down, the blood starts to clot, and you can flick off little clots that can go up and cause a stroke there. Those are caused by blood clots that travel. It would be caused from a large vessel. You can also get blood clots that travel from your heart. They can travel from a defect in your heart called the patent foramen ovale, which is a hole between the top two chambers of your heart. So a blood clot that might not normally be able to get to your brain, that maybe starts in your... Heard of all those commercials on TV about the prophylaxis for deep vein thrombosis. So if you have that hole in your heart, the clot can travel through there from the venous circulation of your blood over to the arterial side and go up to your brain and cause a stroke. Other clots that come from your heart that can travel up to your brain and cause a stroke happen when you are in a rhythm called atrial fibrillation. So your heart has 4 chambers. The top 2 are called atria. The bottom 2 are called ventricles. And it has, as you can see, lovely, thank you, Mary Lee, for holding up that picture. If the electricity in your heart is working right, you have this nice regular rhythm. The top 2 chambers of your heart squeeze the last bits of blood out of it to the bottom chambers, and they squeeze it out to your body and your lungs. Everything is working in order. The electricity is running like it should. So if you can move over to another picture, Mary Lee. There you go. So see how those spikes underneath that heart are irregular, and there's lots of scribbling looking stuff there, and you've got all those little circles going around. So that's the electricity in your heart just out of whack, right? So what's happening is those top 2 chambers in your heart, they're quivering. They're not squeezing, they're quivering. And when they do that, you get stagnant blood flow. And that stagnant blood flow causes clots. So we need to get your heart out of that rhythm. Atrial fibrillation makes you 5 times more likely to have a stroke. And when you throw clots from your heart, the mortality rate or death rate from those kind of strokes is higher, as well as the what we call morbidity or complications, or how much of your brain is going to be affected and how much deficit you're going to have after your stroke. So strokes from AFib are more dangerous, as well as increasing your risk for stroke by 5 times. So once we get through and we kind of run a list, right? It's kind of like taking your car to the mechanic and they run the list and they try to figure out what's causing this thing. We run the list, we do testing, we do scans of your brain, we do, we give you some dye and scan your arteries to see where the blockages are. We do MRI scans of your brain to see where is the stroke. Because I can tell, if you think about a river flowing down a canyon and all of the offshoots, right? So your vessel goes through your brain and all the offshoots. I know that by where I see the stroke in your brain, which vessel was involved, okay? So it should be in one place. If you throw a bunch of clots from your heart, you're likely to have strokes on both sides of your brain. That really shouldn't happen unless it came from your heart, what we call a shower clot. So atrial fib can cause and throw a big clot, which might land in a big vessel down here, and you're getting no flow to this whole part of your brain up here. That's going to be a significant stroke. Or it'll fleck off clots, and you'll get little clots on both sides of your brain. And the symptoms with those kinds of strokes aren't as obvious. You might present confused and have several symptoms that don't make sense. Because if I know if the left side of your brain is affected, your speech is going to be affected, the right side of your body is going to be affected, and I know where to look. But if you flick off a bunch of clots all over your brain, those symptoms aren't going to reflect one territory. So they're hard to pick up if they present that way. But the thing is, you know when your car's making that noise and you take it to the mechanic and you know when you get there it's not making the noise anymore? Yeah. AFib does that. You go in and out of it. So if you're not in AFib while you're in the hospital, while we've got you on a monitor, guess what? And you get through your whole hospital stay and we haven't seen any AFib, and we haven't found any other cause of your stroke, that's cryptogenic. That means we don't know for sure if AFib is what caused your stroke. And we've looked everywhere, all up and down, as much workup as we can do while you're in the hospital. The imaging of your brain, the imaging of your vessels, an echocardiogram of your heart. We have done a few testing to see if you're at risk for clotting disorders. And in the younger population, it's more likely to be what that patent foramen ovale or a clotting disorder. If you're senior and experienced like me, then we're more likely to think maybe AFib was the cause of your stroke. You notice the white hair, those kind of things that go with being a little more seasoned in your life. We're more at risk for things like atrial fibrillation. It's the cause of your stroke. But if we don't,
I say we're at that interesting age.
yeah, something like that. So if you, but in either case, if we don't find the cause of your stroke while you're in the hospital, it's going to be deemed a cryptogenic stroke. The other way it can be deemed a cryptogenic stroke, if there are 2 or more causes, and we can't, and either are equally as guilty of possibly causing your stroke, then we've got to figure out which one. But we're going to give you secondary prevention for both of them, because we're not letting you get away with no secondary prevention either. So if you make it out of the hospital without a determined cause of your stroke, you're at risk because you can't get the right secondary prevention in place. I can't speak to other systems. In our particular system and provider practice, they have a couple of ways to go. They will put you on like a 30-day event monitor when you leave the hospital to look for AFib, or they will go ahead and implant you with one of those devices called a loop recorder. And it's pretty cool because it works via the cell phone network. You go to bed at night and it transmits all the findings to your physician, and they can watch for AFib, and it can stay in for a long time. So, and that tends to be a variation of practice across the board, right? Everybody doesn't practice the same way, but their methods are still looking for the atrial fibrillation. I hope that makes sense. We found over time, the more you look, the more you find, unfortunately. But that's kind of, I guess, in a nutshell, cryptogenic stroke. Our purpose while you're in the hospital to find the cause and to initiate that secondary prevention. So I'll stop here for now if you want to throw your questions at me and see if I can either clarify anything that I've covered so far or if I can answer further questions for you guys.
Okay, yeah, we've got, and if you have a question, please put it in the notes because I'm monitoring on my end the notes. If someone can't really feel AFib, are there any sensations or any way that a person might be able to tell that they have AFib, like before they haven't had a stroke or anything, but is there any signs or, and we have the Be Faster message for us for signs of stroke. Is there anything that's kind of universal for noticing AFib?
Well, believe it or not, self-reporting is the least reliable way to find AFib. You can be in it and not really realize it, okay? There's symptoms that come with AFib that you might not equate to the fact that your heart rate is irregular. Squeeze to push the blood flow on through. That's 15% of your cardiac output. So if you lose that, you could experience fatigue might be your only symptom because you're losing a portion of your cardiac output that delivers blood flow. So a lot of people aren't going to equate that to AFib. You might feel palpitations, maybe not. Not everybody does. You may have some dizziness, shortness of breath. You might notice that your exercise or your activity level is you're getting tired way faster than you used to. But really most, as you can hear, most of that is unreliable. Now we have so many fancy new things. We've got all these watches that monitor your heart rate. That'll give you an alert that your heart rate's irregular.
Okay.
I mean, you can always check your pulse, and it really, literally, it should be very regular. If you are feeling your pulse and it's kind of going bum, 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 not regular, kind of all over the place, then you can check it yourself once a day or twice a day. You should count for a full minute, though.
So
some of those devices.
The Apple Watch, and I didn't know this for a while, and of course it has, a heart, and I use it for exercise to kind of watch that. But I've done, check my heart rate several times. Mine's always fine, and I'm assuming because I'm very, very healthy, blessed to be very healthy. But it is kind of interesting to watch that. But you're saying if you have one of those and you checked it maybe, a couple, 3 times a week, and every time it says it's normal. Of course, it has a disclaimer about they can't diagnose or anything. But if it's irregular a time or two, then that might be something to follow up with but not maybe just one time, but if it seems to be a pattern. Is that accurate or not?
No, absolutely, especially if any of the other additional things. If you've noticed that your exercise tolerance is down, maybe you're a person that walks a lot and you're noticing that irregular notification on your watch, absolutely follow up with the physician, because again, 5 times more likely to have a stroke just with AFib and no other risk factor.
Is it inpatient or outpatient testing to check for AFib? What if I was alarmed and I talked to my doctor and they were going to send me to be checked if I had AFib? Is that an inpatient, outpatient? What would that look like for me?
It can be done mostly all outpatient. You don't have to be admitted to the hospital. But there's all kinds of ways. So they might do an ECG, or where they hook you all up to those 12 leads in the office. But that's kind of like that trip to the mechanic, where if you don't make the noise while you're running, I mean, it's a few seconds. A snapshot of a few seconds in time, right? It's not going to pick up AFib unless you're in it all the time, okay?
Yeah.
They can do a Holter monitor, which is like 24 hours worth of monitoring. They can do, they've got these nice patch monitors nowadays, so they just stick the big patch on you. It'll do 30 days of monitoring, and you turn the device back in and they interpret it. But the ongoing kind of thing with like the implantable monitors, it's injectable. It's really an easy, it's not like a big surgery that you have to do. Some do it outpatient. It's not hard to do, but that particular one, that particular device can stay in for like 4 years, and it's cellular transmission to the cardiologist and with continuous monitoring. So you've got a 24-hour Holter, a 30-day event monitor, and then you've got more long-term solutions.
Okay, so
really, it's
say I've had a stroke. It ends up being cryptogenic by hospital standards. What kind? You want to talk a little bit about? I'd love to talk a little bit about the one monitor that we're most familiar with, the Link. And I've got a sample of one here because I just think this is fascinating, because I think people think so much of this is so invasive. Do you want to talk a little bit about the Link, which is Medtronic's system? There are others, but this is the one that I'm most familiar about because of our relationship with them. So can we talk a little bit about that now?
Absolutely. It's the one I know the most about as well, simply because that's the device that we use in our system. It's gotten smaller since I've been doing this. That's about a quarter of the size of a jump drive, to give you some perspective. And really, they make a small incision and they inject it into the pocket. That's it. They numb you up and inject it, and then the device is activated and you're on your way. So that device, again, monitors, and again, it transmits via cellular wave by a device that's plugged in by your bed, and that's really all there is to it. It goes to your physician's, also, if they have a device clinic or something like that, it'll send an alarm that I've detected irregularity, and then it has to be validated by a cardiologist. So that's how that works.
So I have one of these, and I just go about my business. And
go about your business.
Is someone monitoring me all the time, or is it when something goes awry, they get notice?
Yeah, so it's not like somebody's sitting there watching your heart rate all the time. So what happens is the device has got software inside of it, and that's way over my head how that works, okay? There's software, rhythm detection software, and they've worked over time, because I know my device clinic, it drives them crazy, all the alerts. So they have worked over time to kind of affect that. So it does send alerts and says, hey, I see something wrong here. You need to look at this. So that, and it'll transmit, when it does that.
Yeah. We've got a few watchers, but I'm not seeing any questions yet. So if a stroke survivor is, someone has had a stroke, maybe they're somewhere in recovery, whether it be the acute or the ongoing, but AFib is detected, then this would probably be a cardiac referral, not a neurological referral, or do you start with neurology? Help us. That's, the healthcare system, they do so much more in saving lives and all of that. But sometimes from a consumer standpoint, I've had this, of course, my husband has many comorbidities, but there's been times it's like, I don't know who to call. So I guess, who do you call Ghostbusters, Stroke Busters? I don't know.
I hear that a lot, and it is confusing, and it's distressing that it's that confusing. While you're in the hospital, it depends on what system you're in. Our particular system is really what I can speak to, but there's variation across the board. You usually get admitted to a hospitalist. They consult a neurologist. The neurologist is the one that does the workup to find the cause of your stroke and start all that good secondary prevention I spoke of. If they are going, if they deem you that you're cryptogenic and they think you need a device, then they get, the neurologist will call in the cardiologist to do what's called an echocardiogram, right? They can, look at your heart on the surface, or they can put the tube down your throat and look at it kind of from the inside. They get a better look in there at all the valves and all the chambers and all that, to look for any clots that might be hanging around in your top two chambers and those kinds of things. If they don't see anything irregular, then they'll tell the neurologist, you know what, their heart, I don't really see anything obvious in there. So I don't see a patent foramen ovale. I don't see any clots in there. They call it smoke in the atria sometimes, where it's kind of fuzzy, like there's bloody blood flow in there. They'll say their heart, the echocardiogram looks good. I think we need to look further. So then they will, the cardiologist generally is the one that implants the device, and they are also the ones that monitor the device. They usually have a device clinic, or it comes to their office, depending on how your system or your doctor's office works. If they find, say they get an alert, and months down the road they get an alert and they're like, oh gosh, Mary Lee, it looks like you've got AFib. You need to come in so we can discuss what we need to do about that. The choices for that are you're going to be put on anticoagulation. And I know you guys have seen all the commercials up in your games where AFib, eloquent, come on, they're just like pounding you with those.
And they're always during the nightly news too, because they think all of us old people watch the nightly news.
Really? When have they got that idea? So yeah, absolutely. So the cardiologist is almost always the one that's going to discuss with you the best option for you. There are those newer drugs that are on the market that you don't have to have your blood monitored like you did when warfarin or Coumadin.
Right.
That for 50 years, over 50 years, that's all we had. All we have. There's newer drugs on the market. There's depending on kidney function and those kinds of things. That's why they have to talk to you and look at your history and pick the best drug for you. They really need to customize your anticoagulation therapy, and everybody needs to understand if you get put on one of those drugs, you do never, ever, ever, ever stop taking it without talking to your cardiologist. Okay? Ever, 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 ever. I hope I got that point across. It increases the risk further for stroke if you do that. So please don't ever do that. Don't ever let a random doctor tell you to stop taking it without consulting your cardiologist and neurologist.
Okay. Yeah, consulting with the right people. Well, there's really only one other question that was kind of on our list that our watchers might benefit from an answer, and that is, you're hearing this for the first, say we're hearing this for the very first time. I've always known that nobody knew why I had a stroke. I didn't ever have cryptogenic as the word. And so, say a family member, where would a person start, or how could a person learn? Well, before I finish the question, we are going to put a couple of links that have more information about AFib and about this device and everything in the notes. So when we're finished, I'll put those, they're both links to websites. Or one's a PDF, I think, which helps to explain the unexplainable stroke. But say I'm hearing this for the first time and I want to gather more information to make sure that I'm doing the best I can for myself or my loved one, what would you suggest? So they don't know if they have AFib, they don't know if they don't know anything about their heart or any of that. They just know that the doctor said they don't know why I had a stroke and I'm going on about my life. So what would you suggest for those people? Well, first, shame on them for sending you home like that. Okay. Well, true. Don't let them get away with that, okay? I know it does. And unfortunately, the rate of cryptogenic stroke is as high as 30-some%. And it really depends on the thoroughness of the workup at the beginning. Because, if you don't have the proper expertise taking care of you, they may not do all the testing they need to do. Do you know there are over 200 causes of stroke? Now, most of them fall under what we all know, but there are some more elusive ones that require way advanced workups that aren't going to be finished while you're in the hospital.
And then at the end of all of that, I guess they could still not figure it out. But AFib is guilty of enough that it deserves the attention that you're giving it. Keep up. If you have to go back to your primary care physician and say, look, they had discharged me from the hospital. I still don't know why I had a stroke. I need to figure it out. I want you to refer me to a stroke neurologist until we figure this out. So you have to advocate for yourself and your loved one until you get the answer that you need. Now, anytime that you get in the hospital with a stroke and you get discharged cryptogenic, they're going to make sure that your blood pressure is under control. That's the number one controllable risk factor for stroke. Do you need to be on blood pressure medication? Do you need to be on they'll put you off at least on a baby aspirin. And if you've already been on a baby aspirin, they might change you to something like Plavix, clopidogrel. It's another one of those drugs that make your platelets less sticky. That's kind of the foundation of stroke prevention if you don't know the cause yet. They will talk to you about diet and exercise and managing your good cholesterol and all those kinds of, if you're diabetic and managing that, you should walk out of there with your numbers. What are your goals? What's my blood pressure goal? What's my cholesterol goal? What is my hemoglobin A1C goal? You should know, you should be equipped with all of that because that's how you help prevent another stroke. Maybe those risk factors are okay, but the kind of stroke you had is, like I said, there's a little bit over here and a little bit over here. We know it's in two different territories. That doctor really thinks you probably have AFib, but I can't prove it. You really have to prove that diagnosis to go put somebody on lifelong anticoagulation. It's not just, doesn't come without risk. So you want to be sure you're treating the right diagnoses. But that is our job. It is our job to serve you and tell you what your cause is. And if you are left with cryptogenic and that's it, then there's got to be another game plan for when you're discharged. There are some hereditary clotting disorders that you will not get the results back while you're in the hospital. They require follow-up. Please, please, please make those follow-up appointments. Don't skip those. You've got to finish up, especially if you leave with that diagnosis, cryptogenic. Follow up.
Yeah. Thank you for that. I'm not seeing any questions, and give some, if there's anything, Lynn, that I have kind of forgotten, but there's one question that I have that I think you can answer. And this is, we do camps for stroke survivors and their families, and we've been doing that for 16 years. 15 and COVID. 15 years we did it. 1 year we talked about it. And one of the, and this is outside of AFib. This is just my random stroke question. And this is because I discovered after the first few years of doing camps, my husband is insulin dependent, diabetic. I'm a little bit familiar with the why of all of that. But one of the things that I recognized is so many people did not understand the link between unmanaged diabetes and stroke. So if you don't mind taking a couple of minutes and just give us in layman's terms the understanding of having those high blood sugars, what's going on within your body that puts you at higher risk of stroke. Is that a reasonable question? It's one of those things that frustrated me because so many people had no clue that could be a factor of their stroke.
Okay, absolutely, and it's a great question, and I'll do my best to not talk about it for the next 2 hours because there's a lot of physiology that goes into it that you probably don't need to know, and sometimes I'm guilty of going over the top, so you might need to rein me in.
I'll do this.
Those blood sugars wreak havoc on your end organs, your kidneys, your brain, your eyes, your heart. And it does that by just destroying the linings of your blood vessels, okay? So if you all have, and actually it counts for 2 stroke risk factors all by itself. Mm-hmm. Yeah. So that's the why. You remember I talked about those small vessels deep in your brain? Diabetes, hypertension, and cigarette smoking and high cholesterol just fill those vessels up with junk. And the perfusion to your brain is not good. That's the easiest way that I can describe it. So you are not doing yourself any favors if you don't. And I mean, you just stay on that hemoglobin A1C. And if your doctor says you need to be less than 7%, we're not playing around. You are wreaking havoc. And so it's not just stroke. your kidneys are going to fail.
Oh, right.
You'll be on dialysis. You can go blind. You can do damage to the retina in your eyes. Not to mention the heart attacks and other peripheral vascular disease. You know, the vessels, it's the same plumbing up here and you here and all out in here. It's all the same plumbing, right? All the same lining, all the same makeup. All of those vessels are damaged by that diabetes all over your body. So it's just a massive impact to your body if you don't manage that blood sugar. Did that help at all? Did that answer your question?
Well, that's exactly, and that just reinforces, I've heard similar presentations, similar bits of information before, but it's one of those things that I think, and when we do our stroke education with our youth, so we talk about that. And again, I often use unmanaged diabetes, because if you are like my husband and you're insulin dependent, and he had pancreatitis and lost 85% of his pancreas. So he's insulin dependent for a different reason. But so we work hard with an endocrinologist to manage it. And so I don't feel like he is at any higher risk than John Q. Public in many ways, because we manage it. So that's the piece. I feel badly for people who just want to ignore it. And, you know, I've even heard, and this turns me off, but I've heard it many times at the hospital when they would check John's blood sugar. Oh, you're awful sweet today. And that just goes against my grain, because it has nothing to do with being sweet. It has to do with your health. But I understand that that's kind of an informal, that's kind of a bedside manner and such. So I don't get upset with it, but it kind of gives me a little bit of pause. So
I don't blame you. But one message, Mary Lee, if you don't mind, even people with managed diabetes are at higher risk. Okay.
Right. Yeah. Yes,
if you keep, it's still things not working correctly in your body, and it still can cause damage to your blood vessels. Even if you are managing your diabetes, it's just you're decreasing the damage and decreasing the risk. Does that make sense?
Slowing it down. Yeah, absolutely. Yeah. You're right. Yes, I don't want to minimize it, but it was one of those things that over the first few years of doing the camps, it became so revealed with so many people that did not understand the risk. So that's one of the things that we kind of try and talk about. So there aren't any questions there. Is there anything you can think of, Lynn, that we have overlooked? This has been just enlightening and educational and marvelous. Is there anything else that you've thought of that you want to put in? Then I'm going to talk about what's coming up on our Facebook Lives.
I think we've covered cryptogenic stroke pretty well, and I appreciate the opportunity to do that. The resources that Mary Lee is going to share in the comments are really nice and written so lay people can understand. They're not written for healthcare providers, so that you should be able to understand them very easily. The other thing, and I think I heard her say it earlier, is I want you to be fast. Okay, B is for balance, sudden onset of trouble walking or loss of balance. Eyes, sudden trouble seeing in one or both eyes. Face, sudden droopy face. You can't fake that one. And when you get to the A, that's arms. Does your arms drift? But don't forget about your legs. You can present with a stroke, and the only symptom is 1 weak leg. Just a weakness, numbness, paralysis on one side of the body, sudden onset. Speech, trouble speaking or understanding or looking confused for no reason all of a sudden. Okay? Time to call 911. Don't call me. Don't call your sister whose daughter is a nurse. Don't call your doctor. Call 911, okay? You can't, I don't care if you think you can get to the hospital faster. If there's a wreck in front of you, you don't have lights and sirens to turn on. And if your loved one passes out or otherwise becomes unstable in transit, there's nothing you can do about that. So please, for heaven's sake, call 911. That's what I want to say.
It requires, it's an emergency, and it requires emergent response. Absolutely. Thank you for that.
And for your audience, hopefully that's old news for them, but I'm going to charge you a fee for my appearance here this evening. You have to teach 2 people be fast. Promise?
Okay. Got it.
Okay.
I'm totally with you on that. I'm totally with you on that. So again, thank you so much for your time and your expertise. It's been delightful getting to
You're
know
welcome.
you.